Blood transfusion is associated with adverse outcomes as well as hazards, but no established evidence of benefit. Some patients also object to allogeneic blood. The Bloodless Medicine and Surgery Society promotes the science of providing quality health care to patients without the use of allogeneic blood, with the aim of improving clinical outcomes and protecting patients' rights. Well, medicine and surgery started as advocacy in the 1960s for patients who objected to blood transfusion. Well, the Bloodless Medicine and Surgery Society aims to establish bloodless care, not as an alternative, but as the global standard of care for ethical and evidence-based practice of medicine. All right, let's get some clarity on all of this. I'm being joined now from Calabar by Dr. Nathan Usoro, who is the chairman of the Bloodless Medicine and Surgery Group at the University of Calabar. Thank you so much for joining us. I must confess, bloodless surgery or bloodless medicine and surgery, it sounds quite unknown. To me, and I'm sure so many Nigerians will be wondering how bloodless medicine and surgery. Tell us more about what this means and how it compares to the blood transfusion that we've all known, before now.
Thank you very much, Ngozi, and greetings to the viewers. So, yeah, it does sound a bit strange to some people, but the fact is that prior to 1900, all surgeries were bloodless. It was in 1900 that Karl Landsteiner discovered the ABO and then later the RH blood groups, which then led to blood transfusion being used in the First World War and then in the Second World War. And from the battlefield, it came into civilian practice, just like that. There was no trial, nothing to check whether it works. It was just presumed. Someone loses blood, you put blood in the patient, and everything should be okay. So now, why are we revisiting what used to be the standard in surgery, that is bloodless surgery? I want to re-emphasize it was a standard. Let us remember that Theodore Coker, who is one of the fathers of thyroid surgery, one of the bloodiest surgeries in those days, which was even banned in some parts of the world because patients used to die. Theodore Coker won a Nobel Prize, and that was for carrying out thyroid surgeries with less than 1% mortality. Did he transfuse his patients? No, because this was in the late 19th century, 18-something. So as after this First and Second World War, blood transfusion became like mainstream, it became a normal practice. But as you mentioned in your introduction, some patients would object to blood transfusion. And some clinicians would try to accommodate these patients in line with medical ethics, which says we should respect patient autonomy. And one notable clinician that did that is Dr. Denton Cooley, who in 1962, May 16, he carried out the first bloodless open heart surgery on one of Jehovah's Witnesses. Why is this so remarkable? For one, it was thought that you could do bloodless surgery in other types of surgery, perhaps, but not open heart surgery, which usually require 20, 30 units of blood. But Dr. Denton Cooley, who is now known as the father of modern bloodless surgery, carried this out without blood transfusion. Not only that, he later recorded superior outcomes. Now, take note of that. In other words, patients do better without blood transfusion. And so that is the main reason now the World Health Organization is trying to move us away from blood transfusion, because blood transfusion is not evidence-based. But avoidance of blood transfusion leads to better outcomes. Sorry, maybe I've said more than I should.
Yes, indeed. Let me just come in here. I mean, it's amazing that you say that there's no evidence in terms of positive results. Is that what you're saying as far as blood transfusion is concerned? And in looking up this, it's scary to note that 95% of donor blood units used in Nigeria, according to experts, is actually unsafe. So for every 100 persons who go for blood transfusion, 95% don't get, wholesome blood. Is that what it is? So how important really is this, bloodless medicine when you have this kind of situation in Nigeria, for example?
Ngozi, you've touched on a third vital point. The first 2 points I talked about was patient autonomy, and then I talked about clinical outcomes. The third point you have talked about now is safety. And that is a very big headache for blood bankers, not just in Nigeria, all over the world. It was HIV that really brought this to the fore. But before even HIV, we knew about hepatitis B and C and others. Then after HIV, we came to realize that there are even newer pathogens. Even the latest COVID-19, we know that it goes into the blood. But as of this year, I think the US Red Cross declared a shortage for the first time of useful blood for transfusion. So as you pointed out, Nigeria, and not only Nigeria, most low resource settings, they have a challenge when it comes to safe blood, in quotes, because no blood is really safe except the patient's own blood. So like you said, 95% not unsafe. Therefore, bloodless surgery is something that we have to embrace here. And you know what? This is not my idea. It's not at all. There are my seniors who have published, Nigerians who have published, and their publications are out there. And other African countries, they published that the way out of the problem of blood transfusion in our environment in terms of safety is actually bloodless surgery. They spelled it out. So to the people who have been reading the literature, bloodless surgery is not really a new concept. It is in fact.
How long has it really been in Nigeria? And more concerned about accessibility. I mean, how accessible is this bloodless medicine and surgery to the average Nigerian? I mean, let me just paint a picture for you here. I mean, Nigeria's National Blood Transfusion Service, that's the NBTS, says it collects only about 500,000 units of blood every year, with a shortfall of about 73.3% in Nigeria. So what you're saying is that with this bloodless medicine, we might have a situation where, blood banks will no longer be necessary. But how accessible is this, novel bloodless medicine in Nigeria?
Before I talk on that, let me just mention that you have touched on a fourth reason why bloodless surgery is important, and that is blood shortage, which I mentioned briefly. The US declared, and you have given the statistics for Nigeria. How accessible is it? I can tell you it is very accessible. Some of my teachers actually practice bloodless surgery. And in several centers, there are individuals, physicians, clinicians, who are knowledgeable about the techniques of bloodless surgery. However, is it universal enough? Certainly not. Not even in Western countries. Yes, in the US, for instance, almost every hospital now, it is mandatory that there must be a blood transfusion avoidance program, because the World Health Organization is saying everybody should embrace it, and they are calling it patient blood management. But basically, it is bloodless medicine and surgery given another name. So, but here, it is not, the authorities have not made it mandatory that every institution should have a program. So it's up to us as clinicians to get knowledgeable about this, to share the knowledge and practice it, because it's when we practice it, people see the result, then they tend to come on board. That's the clinician. I can say that in my institution, for instance, I think virtually every clinician is knowledgeable about bloodless medicine and surgery, to various degrees, of course. There are those who are neck deep in it, following up on the latest and carrying out their procedures bloodlessly, even for patients who might not object. Some clinicians have counseled patients in respect of bloodless surgery. Patients accepted, and they were successfully done.
All right, let me Yeah, very quickly. I mean, here in Nigeria, for a pregnant woman who is due to deliver, she's been given expected date of delivery and all of that. One of the things that she's told to ensure she has with her when she comes to hospital is at least 2 pints of blood. Correct me if I'm wrong. What happens to such, women? And what about anemic patients who really seriously do need blood? How does this whole bloodless medicine and surgery work for such people?
Let me start from the last phrase, need blood. Blood transfusion, as you pointed out, there's no scientific evidence of benefits. There is no evidence of efficacy. So if you're talking about evidence-based medicine, you can throw that out of the window. Just last month, the Lancet, which is one of the foremost medical journals in the world, came out with an article demonstrating clearly that transfusing patients who had hemorrhage due to trauma they're in shock, and they're transfused, compared with those who are resuscitated with fluids like crystalloids, colloids, there is no difference. In fact, they use crystalloids. And it is a shocking statement or discovery for some people. But we knew all along because we've been following the literature. I can tell you far back 2007 in UCTH, we formed a multidisciplinary bloodless medicine and surgery group composed of surgeons, anesthesiologists, hematologists, nurses, all stakeholders. So I think many years ago, like in my center, it was mandatory. Every pregnant woman must have blood in the bank and all that. But as time went on, and it was discovered that we were doing cases without transfusion. And some that even donated blood, it wasn't used. And moreover, the outcome was better. We have not, from 2007 till now, I can say we have not lost one single patient.
How do you...
bloodless cesarean sections, we do myomectomies, ectopics, etc., etc. So as time goes on, people get used to the idea, because in the beginning there was a great deal of resistance. But as time goes on, people key into it. Somebody's anemic, why are you transfusing? The WHO doesn't say you should transfuse. That is topping up. Topping up with blood transfusion is no longer acceptable practice. Pregnant women can have oral iron. If we want to raise the hemoglobin very fast, we can use intravenous iron along with adjuncts. So those adjuncts are like vitamin B12, folic acid, various other vitamins, vitamin C. And we can even push the body faster by giving erythropoietin. Not always necessary, but sometimes we can do that. And even over a weekend, we can raise a patient's hemoglobin from Friday to Monday. By Monday, the patient is ready for surgery.
That's interesting you say so. And, as you mentioned this, I mean, I just recall situations where patients who are anemic or who need blood are told, look, go and get the pumpkin leaf, what we know locally as ugu, and, drink as much as you can. And there's the other, vegetable known as hospital is too far. How do all of this factor in this bloodless medicine that you talk about? How efficacious are these?
So I cannot possibly dismiss dietary manipulations in raising the hemoglobin. I have seen these things happen where patients drink, like you said, some vegetable, and they come back with amazingly high hemoglobin. I've had calls to ask a senior person who is a chemist, a lecturer in chemistry, as to how this could come about. And I haven't checked it, but he told me that the structure of chlorophyll is similar to that of hemoglobin, and the body just substitutes a certain aspect of it and puts in the iron. I haven't checked that, but it is true that dietary is a dietary component to raising hemoglobin, which is quite effective if you have enough time, especially. And indeed, there's a dietitian in our bloodless medicine and surgery group who is quite enthusiastic about using that. And again, there is a patient testimony from a sickle cell patient who actually works in my center. And she is not Jehovah's Witness. She has no religious objection to blood, but she doesn't she rejects blood transfusion. And she told me that she just uses diet and she raises her hemoglobin so high that the hematologists get alarmed and ask her to stop whatever she's doing. She has had 2 bloodless cesarean sections, has had a bilateral hip replacement in my center, without all of them, without blood transfusion. Of course, I think she previously also had a normal delivery.
That's amazing. That's amazing to know. But before we go, tell us very quickly, I mean, you have this event coming up on Saturday. What is the focus of that event and how significant is it going to be in enlightening the populace more about bloodless medicine?
So the event is not just on Saturday. In fact, it started yesterday. It's the Bloodless Medicine and Surgery Week. And it is an event that has come to fruition through a collaborative effort of the Bloodless Medicine and Surgery Group in the University of Calabar, the Bloodless Medicine and Surgery Society, and the Society for Advancement of Patient Blood Management. So these collaborative efforts produced a week-long, highly academic educational session, which interestingly, the speakers actually break things down so that if somebody is not a clinician, they can still follow. So we have people who are seasoned practitioners of bloodless medicine and surgery from various parts of the world. Like today, we had a speaker from my own center who is a consultant obstetrician gynecologist. Then there was another speaker from the US who is a professor of anesthesiology, talking on how we minimize blood loss during bloodless surgery. There will be other speakers. We finish for today. Every day it is 1 o'clock to 3:30 p.m. So we have other speakers coming up today. One of them is a professor from my own institution, OIG, because the theme, by the way, the theme for this year is bloodless medicine and surgery in maternal and child health. So we have a very bad reputation when it comes to maternal mortality. But how is it that an obscure center in a low resource setting has been having 0 in the bloodless cases? The only cases that have been dying are the ones who are transfused. So perhaps bloodless surgery holds one piece of that jigsaw puzzle that could help us to completely or to greatly, drastically reduce maternal mortality. So a lot of the topics during the week have to do with that. There's going to be a chief of neonatology from Englewood Hospital in the US who will be talking about how to manage neonatal anemia without transfusion tomorrow. And then there will be a pediatric orthopedic surgeon also from the US on Friday. There will be a chief of obstetrics and gynecology from Malaysia.
All right.
So there's a lot, and how to access the program. You can go on the website of the Bloodless Medicine and Surgery Society. That is just type www.bmssociety.org. Or you go on SABM, that is Society for Advancement of Patient Blood Management, www.sabm.org. You can download the program as well as link.
Very, very useful information. www.bmssociety.org. That's the website. Of course, the event's been going on. It started yesterday, like you said. Thank you so much, Nathan Usoro. Dr. Nathan Usoro is Chairman, Bloodless Medicine and Surgery Group, University of Calabar. Thank you for enlightening us about this. All right, well, that's it for this edition of the Arise interview. Do join us again tomorrow. From me, Ngozi Alebu, and the entire team here in Abuja. Goodbye, and thanks for watching.